Department of Obs and Gyne Unit 3, representing the Grand Round today. So motherhood is a dream of every woman, and as obstetricians, to help the woman realize her dreams, we have to face many challenges, especially if she has pregnancy and malignancy together. So for today's Grand Round, Viral and challenges, navigating pregnancy in the shadows of leukemia and lymphoma, I would request Dr. Rajesh Kumari, additional professor, to conduct the Grand Round today.
Thank you, ma'am. Good afternoon, everyone. So, hematological malignancies during pregnancy is a very rare event, and during pregnancy, prevalence of leukemia is 1 in 10,000, and that is very rare. Addressing these issues related to conception, pregnancy has therefore become an increasingly common medical dilemma, one for which there is limited available information and recommendation to guide patients and physicians. So now we will discuss our experience from past 3 years with hematological malignancies and during their outcome during pregnancy. So Dr. Deepika from our unit will present data, and Dr. Neha, assistant professor from our unit, will further discuss the course of pregnancy and review of literature. And from hematology, Dr. Pradeep Kumar, and from neonatology, Dr. Anu will further discuss their view. Thank you.
Thank you, ma'am. So today we'll be presenting CGR on Miracle and Challenge, Navigating Pregnancy in the Shadows of Leukemia and Lymphoma. So we'll be discussing about the introduction part, our experience with hematological malignancy in pregnant women, challenges faced by the obstetricians, perspective of the hematologist, and concerns of the pediatrician, and review of literature. So malignancy is the second most common cause of mortality in the reproductive age. Hematological malignancy in pregnancy is a rare event. However, early diagnosis improves the outcome significantly, and management approach must take into consideration both the mother and the fetus. Incidence of malignancy in pregnancy is 1 in 1,000. Most common malignancy in pregnancy is breast cancer, followed by melanoma and cervical cancer. And the most frequent hematological malignancy is lymphoma. Given the incidence of lymphoma in pregnancy is 1 in 1,000 to 1 in 6,000, and of leukemia is 1 in 75,000 to 1 in 1 lakh. Coming on to leukemias in pregnancy, management involves complex therapeutic and ethical dilemmas, often presents as medical emergencies, and majority of the leukemias are acute leukemia, out of which 2/3 are AML and 1/3 are acute lymphoblastic leukemia. Incidence of CML in pregnancy is 1 in 75,000, as median age of diagnosis is slightly higher. The CLL, that is chronic lymphoid leukemias, are extremely rare. Coming on to our experience with hematological malignancies in pregnant women, we are presenting the data from 2022 to July 2023, and we have involved 15 patients. Coming on to demographic detail of these patients, we can see that the age group of these women is patients were quite young, to 20 to 25 years. We had 7 patients. And coming on to age of diagnosis also, they were quite young, at the age of 21 to 25 years. We had 9 patients out of total 15 patients. Time of diagnosis, we had 7 patients that were diagnosed before pregnancy, and after conceiving, first presentation was 8, out of which 3 presented in first trimester, 1 in second trimester, and 4 patients presented in the third trimester. Their diagnosis, final diagnosis was 3 patients we had of AML, 4 were presented with ALL, 7 patients were of CML, and 1 Hodgkin's lymphoma. All the AML patients and the ALL cases were diagnosed during pregnancy. Presentation and diagnosis. There can be varied presentations like constitutional symptoms, fatigue, malaise, weight loss. Symptoms of anemia can be there with shortness of breath or palpitation. Symptoms of neutropenia can be there, recurrent infections, recurrent fever. Symptoms of bleeding diathesis, epistaxis, bruising, gum bleeding, and then symptoms of lymphadenopathy like multiple swellings. We had most of our patients with constitutional symptoms presented with fatigue or malaise or weight loss. Outcome of pregnancy, out of 15 patients, we had 3 medical termination of pregnancy that were diagnosed in the first trimester, and 12 patients carried on to term or preterm delivery. Details of the women who underwent medical termination of pregnancy. We had first patient, that is, she was 23 years of age. Diagnosis was made at 12 weeks, and she was a case of acute lymphoblastic leukemia with acute onset hepatitis. She was diagnosed at 8 weeks, and during that time she was severe anemic, so 3 PRBC were transfused, and she was started with induction therapy and maintenance therapy, and the contraception was given with Chaya, and currently the patient is asymptomatic, and maintenance was on maintenance. Second patient is 27-year-old female. She was diagnosed at 12 weeks. She was a newly diagnosed CML who took imatinib in the first 3 weeks, in the first 3 months, that is at 12 weeks. So she was given the option of MTP and she opted for it. After pregnancy, she continued on imatinib. The contraception given was IUCDs, and currently the patient is asymptomatic. The third patient, she was 24-year-old lady, diagnosed at 7 weeks, and she was diagnosed with acute lymphoblastic leukemia in blast crisis. And after MTP induction therapy was started, she was given the contraception LNG IUS, but she expired after 2 months with septic shock. Coming on to antenatal patients, we had 12 antenatal patients, and there were few complications that the patient had. 2 had hypothyroidism, 2 had EPPROM, and 1 patient had tinea cruris. In the fetal complications, 4 patients presented with FGR, fetal growth restriction. Coming on to the pregnancy outcome, we had 8 preterm deliveries, that is the higher rate than the general population rate, and 4 carried to the term. Among the mode of delivery, 9 patients had vaginal delivery and 3 patients had cesarean delivery. Out of the 8 preterm delivery, 3 presented with preterm labor, and rest 5 patients were iatrogenic cause for iatrogenic deliveries for maternal or obstetrical indication. And out of the 5 induced deliveries and 3 cesareans, 3 patients was 3 patients were induced for maternal indication to start chemotherapy as the patient were in crisis. So among the preterm delivery, 3 were in spontaneous and 4 was iatrogenic. The two were induced for fetal growth restriction, and 3 we had to start chemotherapy. That's why they were induced. Details of the delivery done for maternal cause. So 1 patient of AML, she was in blast crisis with thrombocytopenia. She was delivered at 30 weeks by cesarean section, and she expired on post-op day 15 due to fungal pneumonia with ARDS with intracranial bleed. The other 2 patients with acute lymphoblastic leukemias, they were in blast crisis, and they both were delivered preterm. 1 had normal vaginal delivery, both had normal vaginal delivery, and 1 patient was given multiple transfusions throughout the pregnancy because of severe anemia, and the other patient had fungal pneumonia, which resolved after the antibiotics and antifungals. Coming on to neonatal outcome, patient, there were 10, most of them were AGA babies, 2 were SGA babies, all of them had reassuring Apgar score, and there were no NICU admission. However, 1 baby had craniosynostosis in which the mother took imatinib throughout the pregnancy. Coming on to postpartum complication, we had 1 patient that expired because of the sepsis on post-op day 15, and 1 patient had PPH, that was because of the cervical tear traumatic cause. So need of blood transfusion, 5 patients need blood transfusion, but it wasn't a massive transfusion. Most of them had 2 or 3 PRBCs. 1 patient needed 9 PRBC, and that was throughout the pregnancy, and 10 patients didn't need any blood transfusion. Contraception, we advised the patient first. 8 patients were given Chaya, and 2 patients had LNG IUS, 1 patient had IUCDs, and 1 patient had female sterilization. Currently, 9 patients are on treatment. 1 expired, 1 is not on any treatment, and 1 patient, the status is unknown. Comparing the diagnosed hematological malignancy, we had 7 patients of CML, and out of 3 patients of AML, 2 on treatment and 1 expired. The patient had undergone cesarean section. Out of 4 patients, 2 are on treatment and 1 status is unknown. 1 had MTP and that patient expired. 1 is of Hodgkin's lymphoma, and she is currently not on any treatment. We can see the 2 patients that expired are of acute leukemia patients. So coming to treatment and follow-up of these patients, we had 3 AML patients that went up to the normal delivery or preterm delivery. So these 3 AML patients, the preconceptional counseling, because they were diagnosed during pregnancy, we didn't do any preconceptional counseling. During the pregnancy, we gave them the supportive therapy, and treatment after pregnancy, firm was given cytarabine and daunorubicin. The two were given cytarabine and daunorubicin chemotherapy. The one patient did not receive any treatment because she expired on the post-op day 15. And currently, the both other patients are asymptomatic. We had 2 ALL patients, and preconceptional counseling was not done because they were diagnosed almost in the 3rd trimester. During pregnancy, they were given supportive therapy. After treatment, they were given induction followed by maintenance. And one patient is currently asymptomatic. The other patient, we don't know their status. One patient is of Hodgkin's lymphoma. The preconceptional counseling was not done. Before pregnancy, she completed her chemotherapy, and during pregnancy, there were no treatment. She didn't receive any treatment, and after pregnancy also, she didn't receive any treatment. Currently, she is asymptomatic with no residual disease. We had 6 CML patients, 1 CML patient of MTP, and other 6 patients proceeded till the delivery. So they were 2 had preconceptional counseling, and imatinib was changed to interferon, and the rest patients interferon was started in pregnancy. And just one patient, Mrs. AD, she continued imatinib throughout the pregnancy, and this patient had the craniocentosis. Now I would like to call Dr. Neha for the discussion part.
So now we'll come to the challenges faced by the obstetrician. So first and foremost is the diagnostic dilemma in diagnosing these hematological malignancy, followed by the chemotherapy, their induction, and the decision when to start, effect of the chemotherapy, maternal and fetal, termination of pregnancy, timing and period of gestation and mode of delivery, management during intrapartum period, then handling the postpartum period, and main issues are related to breastfeeding because of these chemotherapy agents. And lastly, but not the least, is the contraceptive method we provide to these females. And it is very important that managing these hematological malignancy is a multidisciplinary team involvement, starting from the hematologist, going on to obstetrician, pediatrician, anesthesiologist, and very importantly, counselor is required for counseling these patients. So now coming to the diagnostic dilemma. Why there is a dilemma? Because diagnosis is more challenging as there is an overlapping of symptoms characterizing both the malignancy and pregnancy. So the common symptoms which are encountered in hematological malignancy include weakness, sweating, shortness of breath, or abdominal or back pain, which are usually commonly seen in the pregnancy. So that delays the diagnosis in these pregnant women. First point of suspicion of hematological malignancy in these females are anemia with abnormal blood count and blood film appearances. Again, the invasive and imaging diagnostic procedures, they are usually avoided in pregnancy, and that further delays the diagnosis. But just to emphasize that lymph node biopsy and bone marrow biopsy is required for diagnosis and which is considered safe in pregnancy. So we can always go ahead with these. CT chest is acceptable. However, abdominal or pelvic CT is not considered safe in pregnancy, and the accepted cumulative exposure for fetus is 100 millicurie. PET scan, which is considered gold standard to diagnose lymphoma, is contraindicated during pregnancy. Again, then MRI is an acceptable alternative for making a diagnosis in pregnancy if it is required after biopsy. Now coming to the chemotherapy, as we all know that most of the chemotherapeutic agents, they cross the placenta, hence exposure during organogenesis may lead to major fetal congenital malformations, miscarriages, and fetal death. And again, the physiological changes in pregnancy, they alters the distribution, metabolism, and excretion of these chemotherapeutic drugs. The dosage of drugs should be calculated according to the current pregnancy body surface area. So now coming to the termination of pregnancy, which is the most concerning point for our obstetrician. So we'll just discuss the AML followed by CML. So in AML patient, if the patient is diagnosed in first trimester, according to all standard guidelines and British guidelines, MTP is advised in these patients. And combination, because the combination chemotherapy is associated with high incidence of fetal congenital malformations. Then coming to second and third trimester, now again there is a therapeutic dilemma looking at the gestation of the patient. And these patients can be managed with leukapheresis and or transfusion. Induction of labor and delivery of a viable fetus as soon as the possible is advised, and all the recommended regime whichever is available for the treatment. Most common are the cytarabine and doxorubicin. They are category D drugs. So now coming to the second and third trimester, looking at the period of gestation, we can always decide. So if the patient is diagnosed in early second trimester, like 13 to 24 weeks of period of gestation, we can commence induction chemotherapy, allowing the pregnancy to proceed after careful discussion with the patient as well as the obstetrician. We need to discuss with them. Then coming to 24 to 32 weeks of period of gestation, definitely there is a risk of prematurity which needs to be weighed against the risk of chemotherapy. 32 to 36 is actually reasonable to deliver the fetus prior to commencement of chemotherapy. More than 36 weeks, there is no dilemma. We can go for the elective delivery and followed by the induction of chemotherapy. Coming to the CML patients, like in first trimester, if they are already diagnosed patient, the leukophoresis and interferon alpha rather than TKI therapy, because TKI most commonly we are using imatinib, that is associated with the congenital malformation. So we always switch the patient to interferon, which is safe in pregnancy. Then as already discussed, that supportive therapy is required in all these patients. So low dose aspirin and low molecular weight heparin is used for thrombocytosis. Then second and third trimester, again benefit to risk ratio of TKI should be weighed, and interferon alpha and leukophoresis may be preferable. Coming to the maternal effects, when we start the chemotherapy during pregnancy, chemotherapy may result in neutropenia and increased risk of life-threatening infections in the mother. Broad spectrum antibiotics and intensive support may be required. Blood transfusion can be safely given to support the pregnancy and according to the counts. Granulocyte colony stimulating factor is considered to be safe, however, the data is limited during pregnancy. Coming to the fetal and the neonatal effect, first trimester exposure to chemotherapy has been associated to almost 10 to 20% risk of the major malformations. Induction of chemotherapy in second trimester onwards again is not associated, is again associated with the fetal and neonatal effect. It increases the risk of late miscarriages, fetal malformations, fetal growth restrictions, and perinatal mortality. Suspected causes of fetal death in such females is usually maternal anemia, disseminated intravascular coagulation, and leukemic cells affecting the blood flow, nutrient exchange, and oxygen delivery in the intervillous space of the placenta. This is just to summarize the effect of the potential fetal toxicity caused by the most common agents employed for treating lymphomas and leukemias. Coming to the individual drugs which we commonly use, impact of anthracycline on fetus. It is in general is cardiotoxic to the fetus, especially during the first trimester with exposure between 2 to 8 weeks of period of gestation. Daunorubicin or doxorubicin, they are used in preference to idrarubicin because it is more lipophilic and favoring more placental transfer. So we can monitor the baby. Serial perinatal sonographic assessment of fetal cardiac function is advised in such females. Transient neonatal cardiomyopathy has been reported with idarubicin but not with doxorubicin. Coming to cytarabine, again the fetal congenital malformation occurs during exposure in first trimester. Congenital malformations commonly include limb malformations, reported to cause transient cytopenia, intrauterine fetal death, fetal growth restriction, and neonatal death secondary to sepsis. And role of hydroxycarbamide, it is used in cases of high white cell count for early control, otherwise it is avoided during pregnancy. So coming to maternal and the fetal monitoring, patients undergoing chemotherapy, they need a regular obstetric and hematological review. Fortnightly ultrasound scans for growth and fetal well-being to detect the fetal growth restriction, which is commonly found with the chemotherapy drugs. Vigilance for signs of infection and high index of suspicion is necessary, as pregnancy and malignancy, both they increases the risk of sepsis during pregnancy. So the termination of pregnancy regarding the mode, planned delivery is always preferable to allow timely administration of subsequent chemotherapy. Delivery should be avoided during maternal nadir period, usually 2 to 3 weeks after treatment. And delay of 2 to 3 weeks after chemotherapy, it facilitates the fetal drug excretion, thus reducing the risk of neonatal myelosuppression. Vaginal delivery is preferable because of the lower risk of infection and quicker recovery. Therefore, the induction of labor is normally recommended. Cesarean section is advised only for the obstetrical indication. Again, instrumental delivery is also not contraindicated, as chances of fetal myelosuppression is overall low. Then early involvement of anesthetic team for the labor analgesia is recommended in all the cases. Coming to the postpartum management, appropriate chemotherapy to be planned as soon as feasible. Remission status, prognostic risk factors, and the number of cycles already given during pregnancy, you should always take a prior taken into account when you are starting the chemotherapy in a postpartum period. We should avoid mother-baby separation as much as possible. Breastfeeding is not recommended while the mother is undergoing chemotherapy and until at least 2 weeks following the chemotherapy completion, because the drugs will be excreted in the breast milk. So coming to the previous studies, so regarding the hematological malignancy, we have only the retrospective studies and the large case series. There are no prospective kind of a studies. So regarding the CML, this is one study, retrospective study conducted by ASI et al. In 2021. They have included total 15 patients of CML. And the treatment during pregnancy, they have received hydroxyurea, interferon, leukophoresis, nilotinib, and 5 patients were under observation only. Related to the outcome, 12 patients had live birth, 2 patients had spontaneous termination, and 1 had an elective termination. And TKI, tyrosine kinase inhibitors, are started after pregnancy, after delivery. And this is imatinib, dasatinib, and nilotinib. Adverse outcome is seen in only 1 patient who expired because of the blast crisis out of 15 patients. Then there is another retrospective ambidextrous study. Is a retrospective and prospective by Chelisheva et al. In 2018. They have included total 48 patients with CML, and the treatment received is again TKI and interferon, and 14 patients were under only observation. Then related to the outcome, 33 had a live birth, 1 patient had a spontaneous termination, and 14 had an elective termination. And after pregnancy, all of them were started on tyrosine kinase inhibitors. 2 had a blast crisis and expired after delivery. Then this is another retrospective study conducted by Madhubhavi et al. In 2019, and they have included almost 46 patients of CML. Again, the treatment during pregnancy included hydroxyurea, interferon, leukophoresis, imatinib, and 9 were under observation only. 25 had live birth, 17 had a spontaneous termination, and 4 had an elective termination. 1 patient expired because of blast crisis, and 2 had fetal malformations. 10 patients, they continued imatinib despite counseling, and 2 babies had malformation. 1 had a craniosynostosis and other had a omphalocele. Coming to the AML series, so this is a retrospective study conducted by Wang et al. In 2021. They have included total 52 patients of acute leukemias. 6 patients were diagnosed, treatment was started in first trimester, and in 11 patients in second and third trimester, and 35 patients treatment started after abortion or delivery. And 17 patients were treated with chemotherapy, 26 had abortion, 26 had elective deliveries. And 19 patients expired in this study due to relapse and blast crisis. Then there is another retrospective study conducted by Wheelit et al. In 2020. They have included 17 cases of PML. 4 were treatment commenced in first trimester, 7 patients in second trimester, and in 6 patients treatment started in third trimester. 17 patients had chemotherapy, and out of 17 patients, elective had elective abortions, and 6 had elective deliveries. 1 patient expired due to refractory AML. In both these studies, exposed cohort has more premature neonates with evidence of FGR because of the commencement of chemotherapy during the second and third trimester. This is the another Zhu et al. Conducted a retrospective study in 2021, and they have included 21 cases of acute leukemia. Again, the 6 had treatment commencement in first trimester, 8 had in second trimester, and 7 in third trimester. And 16 patients were treated with chemotherapy. 6 had elective abortions, 1 had a spontaneous abortion, 4 underwent normal vaginal delivery, and 5 had a cesarean, and 4 patients expired because of, again, the relapse and blast crisis. But in all these studies, the cesareans were done for the obstetrical indication. Only few patients in which we have done the elective termination to start chemotherapy. In those, they did the cesarean. Now I like to call Dr. Mehak. She's a senior resident from the Department of Hematology, and Dr. Pradeep Kumar, from assistant professor from the Department of Hematology, to give us some perspective from hematology side.
A very good afternoon to all. Myself, Dr. Mehak Trehan, and I will be covering the hematological aspect of the management of hematological malignancies and pregnancy. So, starting with the most common amongst the leukemia, that is the acute myeloid leukemia. In the simplified language, a patient of acute myeloid leukemia, if she presents in the first trimester of pregnancy, the idea is to terminate the pregnancy and to commence with the chemo. And if she presents in second and third, we have to start the patient on 3+7 regimen. But in this, there's a clause that if the patient presents between 24 to 34 weeks of POG, the risk of fetal chemotherapy exposure, it must be balanced against the risk of prematurity following elective delivery. So, and we are not supposed to give the chemotherapy beyond 35 weeks of POG, as if we give the induction, the patient is likely to deliver in a phase when she is cytopenic. So, the data of AIIMS New Delhi of AML in the past few years, we have had 3 patients of AML. All of them were diagnosed during the pregnancy. 2 of them were at POG 36 and 37 weeks. Both of them went for induced labor, and the chemotherapy was started post-delivery. There was this one patient who was at POG 28 weeks, and here we had to balance between the fetal risk and the exposure to chemotherapy to fetus and the maternal disease. So she underwent MDB, and she was started on azacitidine venetoclax, but she succumbed to her illness due to intracranial bleed and febrile neutropenia and shock. So, coming to acute lymphoblastic leukemia. So, very in simple of the terms, if a patient of ALL comes in first trimester or anywhere between less than 20 weeks of second trimester, the idea is to go for termination of pregnancy. And beyond that, we start with chemotherapy in a modified protocol where we exclude methotrexate because it is known to cause the amphiterion syndrome. Coming to the data of AIIMS New Delhi of ALL in the past few years, we have had 4 patients of ALL. All of them were again diagnosed during the pregnancy for the first time. Since 2 of them were close to the period of delivery, that is 30 and 32 weeks, they were given pre-phase steroids and labor was induced and induction was started post-delivery. The patient is asymptomatic, and the status of another patient, it's not unknown, but she was doing well till June 2023. 2 of the patients presented in the first trimester, that is 6 and 12 weeks respectively. Both of them underwent MDP, and induction was started post-delivery. And in those 2 patients, one of them succumbed to her illness in view of sepsis, septic shock, and status epilepticus. Coming to chronic myeloid leukemia. So, most of the chronic myeloid leukemia patients we have had, they present in chronic phase. If they present in accelerated or blast phase, the idea is to treat them like AML or ALL. So, if a patient of chronic myeloid leukemia comes to us in chronic phase, she has an unplanned pregnancy, or the diagnosis of CML is done during the pregnancy. The idea is to stop the TKI since it inhibits c-KIT, BCR-ABL, and causes negative effect on the fetus, and it's teratogenic. And we can start the patient on leukophoresis and consider interferon alpha. There is now data to give TKI during the second and third trimester if the patient has rising BCR-ABL counts and if the patient is symptomatic despite giving interferons. So, coming to the data of AIIMS New Delhi for the CML, we have had around 7 patients of CML in the past few years, out of which 2 of them were first aware of CML during the pregnancy. So, they were both started on interferon and switched on to TKIs in the second and third trimester in view of loss of the response. Another patient, she was already on TKI and she was unaware of her pregnancy till 3 months. So, there was a risk of congenital abnormalities and she went ahead with MDP. We had this Another patient who was again unaware of pregnancy, she was on TKI in the first trimester. Even after explaining the risk of congenital abnormalities, she continued with the TKI and had a kid with craniosynostosis, as mentioned by my colleagues in obstetrics and gynae. Another patient we had, that's an ideal case, Mrs. H, she was on interferon. She had a good response on interferon. So she was continued on interferon in the second and third trimester, which is the ideal situation. And post pregnancy, the idea is to start on TKI immediately. But because she had no loss of her deep molecular response, she breastfed the child for 2 months. So coming to the lymphomas, among the lymphomas, since the Hodgkin lymphoma has the peak between the age group of a childbearing woman age, so maximum of the cases we have had of lymphoma only. In very simplest of terms, if a patient on lymphoma comes during the first trimester, we defer the treatment until second and third. In second trimester, the idea is to start with ABVD, and third trimester again to defer the treatment until after delivery. But the clause is that at any point of time, patient with symptomatic or progressive HL that threatens the immediate well-being of the mother, we are to start the patient on ABVD. We have had only one patient of Hodgkin in the past out of AIIMS. So she had completed her treatment, her 6 cycles of ABVD when she had her pregnancy. So it was an uneventful event and there is no abnormalities in the kid as well.
Thank you, Dr. Mahek. Now I like to call Dr. Anu from the Department of Neonatology to give us views on the effect of the fetal effect and neonatal effect.
Good afternoon, everyone. So, as far as fetal effect is concerned, we heard a lot from both obstetrics and from hematology. So, if we bypass, we go away from the first trimester and the mother actually takes a decision to continue pregnancy, and obviously we're not giving chemotherapeutic agents. So, you see the pregnancy outcomes and you review the literature. So, for these particular babies, we had 2 babies with low birth weight and no baby with IUGR, and the other baby is delivered either late term or at term, and they are apparently doing well. So, but in the 2 babies that were delivered preterm, it was induced prematurity primarily with an indication to start the mother on chemotherapy. The concerns as a neonatologist that we often are worried about is breastfeeding. So WHO recommends, we all also agree with the same guidelines, that exclusive breastfeeding for 6 months, which is not possible in this particular scenario. So short of that, we do check out for feasibility of either formula feeding or animal milk feeding, whatever is possible. But given except for breastfeeding, which is actually the biggest drawback when the mother is started on chemotherapy, there are no major concerns as far as the neonatal issues are there. So no major health problems and no other issues except some social issues, because the primary caretaker, the mother, would not be there for most of the time. So some other caretaker in the family has to step forward and take care of the baby. So except for that, no major worries for the neonate, provided the chemotherapy is not continued in pregnancy, except for one baby who actually has had craniosynostosis. So people have actually associated imatinib with craniosynostosis, but the strength of this relation is not significant enough because there are only few case reports about imatinib with craniosynostosis. And the other, except for that, breastfeeding is the only concern that we as neonatologists need to plan about, discuss actively with the family, and identify another caretaker in addition to the mother who will be taking care of the baby. Thank you.
Coming on to take-home messages, so diagnosis is more challenging as there is overlapping of symptoms and invasive diagnostic procedures are usually avoided in pregnancy. Approach and management must take into consideration both the mother and fetus. Management approach in first trimester usually MTP, as the chemotherapy during organogenesis period leads to major congenital malformation. Second trimester onwards, benefit versus risk of chemotherapy needs to be weighed and considered and discussed with the patients and the relatives. Maternal effects of chemotherapy include neutropenia, so increased risk of sepsis is there, and bleeding is there because of anemia and thrombocytopenia in both the antepartum and postpartum period. Fetal effects include increased risk of congenital malformation in first trimester if given chemotherapy, and increased risk of prematurity, fetal growth restriction, and perinatal death afterwards. So I would like to thank head of the Department of Obs and Gynecology, Department of Hematology, Department of Pediatrics, and Department of Anesthesiology, and all of our patients. I would like to call Dr. Rajesh to conclude the CGI. Thank you.
So, pregnant women with the hematological malignancies should be managed by a multidisciplinary team, which include first from diagnosis of these malignancies in pregnancy, wherever they are coming, in hematology department or obstetrician and gynecology. And they include a hematologist and department of obstetrics and gynecology, neonatologist, and anesthesia. Women who are diagnosed with acute myeloid leukemia or ALL in pregnancy should be treated without any delay when they are coming in blast crisis. The risk-benefit ratio must be considered before using any drug during starting any chemotherapeutic drug starting during the pregnancy. And whenever possible, delivery should be planned for a time when the woman is at least 3 weeks post chemotherapy to minimize risk of neonatal myelosuppression. And it is reasonable to adjust therapy option to pregnancy trimester and to avoid any potential teratogenic effect of drugs on first trimester. So a careful follow-up and timely monitoring of these patients and management is needed. Now at the end, I would like to request Vatsala ma'am to say expert opinion about these patients.
One question, when you're reviewing the literature, is there any case of like sort of a transplacental transmission or a newborn being? Because that is also maybe one of the concerns when patients continue pregnancy when they have leukemia.
Ma'am, most of these, when we review the literature, most of these are case series, not a vast data is available regarding these hematological malignancies in pregnancies. So there are lots of these are retrospective studies with case series. So no present.
I think well presented series of cases and well managed with multidisciplinary support. And of course, it is challenging because we are always dealing with two patients, it's the mother and the fetus. So we have to see the effect of the disease on the mother, on the fetus. If you're giving any chemotherapy or any drug for that matter, how is it going to affect the mother and the fetus? So a very careful decision has to be taken to start chemotherapy or whatever medication, keeping in view both the lives. Thank you. Would you like to say a few words from your experience?
Thank you, ma'am. Management of hematological malignancy in pregnancies depends on the urgency of the condition. Like in AML, it's an aggressive malignancy. If we don't treat, then patient and baby both suffer. Like in a CML case, it's a chronic problem. If patient's molecular response is good, we can manage safely without medications. With treatment-free survival, we can provide her. If not, if there is an increase in molecular parameters, so we have to add set. It's all depends on the urgency where we are standing during the period of pregnancy. That's all. Thank you.
Any questions?
Suppose we have a patient who has acute leukemia, blast weeks of gestation, and the family has decided to disregard the pregnancy. Blast crisis, her MPP is very risky. So how should we proceed?
should we go on stabilize, do the MPP first and starting then the chemotherapy, or should we start the chemotherapy, keeping the fetus inside, and then she will go in labor whenever she goes, considering that she has discarded inside?
At 26 week with the blast crisis. So first we have to stabilize the patient. During blast crisis, any infection is there, any other condition is there, first we have to treat her as a symptomatic treatment first we have to give, then we have to start chemotherapy and consider as for MTP.
Patient with crisis, if a patient's TLC is in lakhs, what is the risk? We have to treat disease as well as the termination of pregnancy. As soon as possible, termination and simultaneously. If patient is having 3,000 of years, then we should think of first termination of pregnancy, then what happens? Urgency. She's saying the patient and family wants to disregard the.
And she is at blast crisis and they want termination of pregnancy and she is in crisis. So first we have to stabilize, then we have to stabilize, then chemotherapy, then termination of pregnancy.
20 weeks terminated within 1 hour.
They don't want termination. They have just said that the family saying that we care about the mother, so we have disregarded the child. So is there an option that we can start the chemotherapy?
Yes.
Basically, bad.
Always the mother plays always think of the mother first. So you have to treat.
Yes, for the MPP first.
The chances of baby survival is very less. In fact, 20 years. If she is having 32 weeks, so we can have a chance to reward that.
Closer to the before the next 6 weeks, maybe we can that is fine. Would she pick a neighbor or
So, is it possible that she can just join the
Baby, we can continue therapy. We have to counsel the patient. The patient has received the medication. We are not able to see the ultrasound. The baby can have problems.
She can
We have a over 5% follow-up with pregnancy. Majority of patients deliver safely with normal. Only one or two patients has
10 patients had
Data.
but still data is insufficient.
Only in one pregnancy. This is rare congenital malformation, and this is with we have out of 12, only one baby has shows craniosynostosis. Thank you.